Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out and return your program evaluations. And if you could give the CME committee any ideas in regards to topics or speakers, we're always appreciative. Today, it's my pleasure to actually reintroduce Dr. Amal Rahhal. Dr. Rahhal is a professor of internal medicine in the Department of Endocrinology and Metabolism at the University of Iowa. She is also the fellowship program director in the Department of Endocrinology and Fellowship, and she is also assistant dean for student affairs and curriculum at the University of Iowa. We're very pleased that she was able to accept our invitation today to provide us with an update on osteoporosis and bisphosphonates. And please join me in welcoming Dr. Rahhal.
Maybe I need to be Oh, now it's working. Very good. Okay, so I was asked to this time give you an Osteoporosis 101 talk. For those of you who were here, like at my last talk in the fall, you will notice that this is a little bit, I'm kind of regressing, not in the sense that it's less important, but it's kind of older data a little bit. So we're starting from the beginning now, more or less. I will be focusing on basic concepts, when do you diagnose osteoporosis, how do you diagnose it, how do you make the decision to treat, and talking about bisphosphonates, their benefits, the risks, the side effects, and why those happen. I have no disclosures today, and my objectives are the following. They may not necessarily occur in that particular order because the slides are kind of jumbled up a little bit to follow cases. But by the end of this talk, I hope that I would have explained to you the mode of action and clinical effects of bisphosphonates. Why do they do what they do? Explain the anti-fracture effects of bisphosphonates and their side effects. And then hopefully we will have a better understanding of when to screen for osteoporosis, how to interpret DEXA scan results, and based on that, how to formulate treatment plans for patients who have low bone density. So I'll start by talking about bisphosphonates, the good, the bad, and the confusing, and there's a lot of confusing. But first I would like to quickly review bone turnover. So this is basic bone biology. There's much more to bone biology than this, but this is really kind of the basic understanding that will help us place bisphosphonates into a working, a framework. The two main cells that affect bone turnover are osteoclasts, which are the bone breakers, and osteoblasts, which are the bone builders. And those two cells talk to each other. So what happens on one side eventually happens on the other side. There's a crosstalk between osteoclasts and osteoblasts. And a typical bone turnover cycle starts with the osteoclasts breaking down bone that needs to go, creating what we call resorption pits. And then the osteoblasts get activated and come in, and they fill up the resorption pit with new bone matrix. So this is the protein matrix that makes up sort of the backbone of our bone. And then the last phase would be mineral deposition on this protein matrix. So the calcium and the phosphorus they crystallize and mineralize the bone. So phase 1 is bone breakdown, phase 2 is bone buildup, phase 3 is mineral deposition, and then it starts again. And that's a bone turnover cycle. Now, what do the bisphosphonates do? What they do is that they attach to the bone surface, and they get internalized. The osteoclasts take them inside the cell, and once the bisphosphonate molecule is inside the osteoclast, it does all kinds of badness to the osteoclast. So at the extreme, it can cause osteoclast apoptosis. It could decrease differentiation of the osteoclast, but it also impairs the function of the differentiated osteoclast. So the osteoclast needs to make this ruffled border here so it can stick to the bone surface in order to break down the bone. The bisphosphonates will impair formation of the ruffled border. They will impair adherence of the osteoclast to the bone surface, And they will also impair secretion of acid, which is important to be secreted by the osteoclast to promote dissolution to dissolve the bone. So they impair the function of the osteoclast at many levels, but also they could promote osteoclast death. What's the result of that at the molecular level? The osteoclasts are being killed or disabled, so bone resorption is gonna basically stop or be slowed down or completely discontinued. So bone resorption will come down like that. Bone formation eventually will come down because remember how I told you the clasts and the blasts talk to each other, so whatever happens on the building side will be mirrored on the breaking side, and whatever happens on the bone breaking side will be mirrored on the bone building side. But there's a little bit of lag time before the osteoblast is completely disabled. And there is, during this period of time when the osteoclast is disabled but the osteoblast is still coming down, there's a little bit of a window for catch-up bone building. I don't want you to leave this talk thinking that bisphosphonates are bone-building drugs. They are not. They inhibit osteoclasts, so they prevent the loss of bone. But as a result of their effect, there is a small window for catch-up for the bone to do. The biggest effect, though, happens here in that by slowing down the osteoclast and slowing down the osteoblast, so this is phase 1 and phase 2 of the bone turnover cycle, then phase 3, which is the mineral deposition, becomes longer. So there's more time for mineral deposition on the bone. And this accounts for most of the increase in the bone density that we see with bisphosphonates. Some of it is new bone, that some catch-up building of bone like happens here, but a lot of it, I'm sorry, the mouse is lagging behind my motions. Some of it is catch-up bone building, but a lot of it is increased mineralization of the bone. And that basically leads to increased bone volume and bone density. Now, we're not just increasing the bone volume in quantity. What actually happens is that the bone quality also improves. This is a biopsy of lumbar vertebra in a patient with osteoporosis, and you see how not only is the bone thick, but the bone is poorly connected. And then after treatment with alendronate, the bone itself is thicker, but then more importantly, the architecture of the bone is restored. So you see more interconnections within the bones, and that gives the bone structural stability. We've all seen this data or something that looks like it. I've gone all the way back to the FIT trial, which was one of the original alendronate trials, but every other bisphosphonate trial has shown the same thing. You treat someone with a bisphosphonate, which is the red line here, and their bone density, in this case it's alendronate, the bone density at the hip and at the lumbar spine will increase in comparison to placebo, which is the blue line. More importantly, you will get significant protection from fractures. And really, at the end of the day, this is what we care about. I mean, we want the bone density to improve, but what's more important is to prevent fractures. What I put in this table is a summary of several studies that look at the different bisphosphonates out there and their effect on vertebral, hip, and non-vertebral fractures. And you will see that they will all decrease fractures at all sites, except that ibandronate does not decrease hip fractures. So that's a little pearl to keep in mind. Ibandronate has not been shown to decrease hip fractures. So that's the limitation to the use of this particular drug. All of the others decrease all fractures. Now, it might look here that zoledronic acid might be more efficacious than, say, risidronate or alendronate at decreasing vertebral fractures. Might be, but I would take that with a grain of salt because these are not head-to-head comparisons. These are comparisons of each drug against placebo. So there's a lot of design heterogeneity in the drugs, and we cannot confidently conclude that one is better than the other. But what I want you to take away from this is that these drugs are all effective at decreasing fractures. So that's the good. We put someone on bisphosphonate, we increase their bone volume, we increase their bone mineralization, we restore their trabecular architecture, and that is going to enhance both bone strength and is going to decrease osteoporotic fracture. So that's all good. Now, we all know that there's no pure good with drugs, right? There's always the bad side. So let's talk about that. Let's First, review the bone physiology again. So our friendly osteoclasts, their job is to break down the bone, and then the osteoblasts would follow and would build the bone matrix, and then we mineralize it. So there's a reason why this phenomenon exists in us, and that is the main phenomenon that our body physiologically uses to repair damage that happens to our bone from wear and tear. You know, just the normal stuff we do every day, you know, the walking, the jumping, the running, the stairs, the occasional falls, whatever it is, the things we bump into. And just the fact our bone is getting older, just like our skin gets older and our hair gets older, and we shed it and we surface new skin and new hair, we've got to surface new bone. So that's the way our body, our skeleton renews itself. So when we put someone on a drug that is going to stop osteoclastic function and as a result stop osteoblastic function, then the counterpart of us improving their bone density and decreasing their osteoporotic fracture risk, we're inhibiting their ability to repair the wear and tear that happens naturally to their bone. So as a result, they accumulate damage to their bone, which we call microcracks. And I have here a slide from a dog experiment that was treated with high doses of bisphosphonates for 12 months. And these are the microcracks. And they were able to demonstrate in this experiment that there was an increase in the microdamage accumulation and an increase in the length of the microcracks. This is a rib bone in the ribs of the dogs. So it is believed that, a similar experiment has not been done in humans, but it is believed that the wear and tear that probably we normally accrue to our skeleton when you are on prolonged treatment with bisphosphonates, we probably are developing microcracks in our bone as well that goes unrepaired. Another phenomenon that happens when you treat someone with bisphosphonates is decreased elasticity. Remember how I told you that you inhibit phase 1 and phase 2, which is bone breakdown and bone formation, and then you have more time for phase 3, which is bone mineralization. So now the bone has much more time to accumulate mineral on it, which is good for strength, but is bad for elasticity. The tissue is becoming too stiff and too homogeneous. And as a result, when our bone gets a blow, which could be as simple as walking on my heels now, my bone has to deal with all kinds of forces to keep the balance. And normally it has the ability to bend to accommodate those forces. So when you make the bone too stiff, then it loses that ability to dissipate forces that it has to deal with. So the combination of decreased bone turnover and increased homogeneity or increased mineralization is leading to microcracks and decreased elasticity. That's a bad combination for the bone, right? If you have a bone that has cracks and it cannot softly bend to accommodate forces, then guess what's going to happen? It will crack. Okay, so that's how subtrochanteric fractures can happen. And the definition of a subtrochanteric fracture is a fracture that happens anywhere along the femoral shaft from under the greater trochanter to from under the lesser trochanter, to right above the femoral epicondyle flare. Most of them happen more proximally, but occasionally they might be seen more distally, but the vast majority are going to be higher up in the femur. And they can be complete, meaning the femur is broken into two pieces, or they can be incomplete, a partial fracture. So it's broken on one side, but the other side is still in place. Typically, these fractures happen with no trauma or minimal trauma. A common story for subtrochanteric fractures I've heard from my patients are, I was getting out of the car, I put my foot on the floor, and I heard something crack in my femur. Or I was getting off the curb, and I heard something crack, and I fell down. So it's typically just a little change in mechanics and using their body, but not real trauma. They tend to be transverse or short obliques. I'll show you a picture of that. So this is a typical transverse fracture, just flat, horizontal, and this is a short oblique fracture. But as you might notice, they're more or less clean fractures, as opposed to some of the comminuted fractures that you might see when someone comes in, say, with a motor vehicle accident and a leg fracture. Those tend to be more messy. The bisphosphonate-related fractures seem to be more clean-edged fractures. And they often have this little peak associated with them. Some of the studies suggest that these findings are pretty specific for bisphosphonate-related fractures. If you're lucky enough and you happen to grab an X-ray of your patient before they get that fracture, you might have a hint that there's an impending fracture, because you might see something like this, which is cortical thickening and sometimes a little bit of peaking or beaking in the femur, in the cortex of the femur. This is really the femur trying to tell you, I'm very stiff, I'm dealing with a lot of forces that I cannot accommodate anymore, so in reaction to that, my cortex is becoming thicker to try to prevent fractures. Okay, so this is a stress reaction from the femur. Now, I have no idea how, I think this and this are the same patient or something like this. Some of these fractures are sequential. So I have no idea how they caught the patient at different stages. But you can catch it because up to 70% of the patients who are going to have a subtrochanteric fracture will tell you, will experience, will not tell you necessarily, will experience pain in that hip or in that groin for a few months before the fracture happens, okay? I used to, if a patient is on bisphosphonates and has osteoporosis and they would come to my clinic and say, you know, doc, my hip has been hurting the last few weeks or whatever, I used to tell them, oh, osteoporosis doesn't hurt, it must be arthritis, don't worry about it. Well, now if they say my hip hurts or my pelvis hurts or anything in that area hurts, I do an X-ray. And I ask my radiologist specifically to look for a femoral cortex stress reaction, because the patient is on anti-resorptive therapy. Because if I see a stress reaction, I know that they're at high risk to develop a subtrochanteric fracture. Now, there's a little bit of controversy. What do you do with that? If the fracture has not happened yet, a lot of people would pin it. I would send them to an orthopedic surgeon and just put a pin in that hip so it doesn't break. It hasn't happened much. I had one case like that, and I did send the patient for pinning, and the surgeon did pin it. Some people, you know, just stop the bisphosphonate and hope it will go away. Typically, the risk is very low, though. Like, I'm not saying this to scare you and make you think that, oh, don't use bisphosphonates. If the patient is going to benefit from bisphosphonates otherwise, I wouldn't withhold treatment, because the risk is about 1 per 1,000 patients per year. So really, the risk is very small, and it's very important to keep that number in mind, because a lot of patients who really need to be treated refuse treatment because they're scared to death of this. And so it's very important for us to be able to tell them what their true risk is. It's 1 per 1,000 per year. And it typically, usually, does not happen after short-term treatment with bisphosphonate. The median duration of use is about 7 years. So typically, if you're going to treat them for 3 or 4 or 5 years, more often than not, you'll be okay and they will be okay. It's usually mostly prolonged treatment that is problematic. Okay. Now, the other scary story about bisphosphonates is osteonecrosis of the jaw. So patients come in and say, oh, but my dentist told me I should not use these because my jaw will dissolve, right? Have you heard that one? My jaw will dissolve. Their jaw is not going to dissolve. Osteonecrosis of the jaw is actually an infection of the jaw. It's not a dissolution of the jaw. And why does it happen? For the same reasons I just explained to you. The jawbone is just like any other bone, so it can accumulate microcracks, and it will have low turnover because the patient is on bisphosphonates. Now, our mouth is not a sterile, clean environment. There's tons of microbes in our mouth. So if microbes sit in those little cracks, then our bone does not have the capability to efficiently clean itself up. In addition, bisphosphonates have some anti-angiogenic activity. That's why they are used in certain cancers, and multiple myeloma and metastatic cancer to the bone. So the combination of all of the above predisposes that area where the microbes seed and sit in the cracks that have decreased blood supply and decreased turnover, then the bone could get infected. So that's osteonecrosis of the jaw. It's not temporomandibular joint dysfunction. It's not my jaw is going to dissolve. It's not a receding gum. That is not bisphosphonate related. Now, what's the risk of that happening? 1 in 15,000 per patient. 1 in 15,000 per year per patient. So it's really a very low risk, and actually that's the conservative one. There's some literature that says 1 in 100,000 So this is the more conservative estimate of risk. So the risk is very, 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 very small. Now, of course, if you listen to TV shows and you read, popular literature and what have you, patients come, scared to death that, their jaw is going to dissolve. But that's not true, really. The highest risk is with invasive procedures. Now, not to say it doesn't happen spontaneously, but mostly with invasive procedures. By invasive, I mean implants, surgeries, something that cuts through the gum. So cleaning of the teeth, fixing caries by doing fillings, doing crowns, root canals, these are not invasive procedures. The patients can have their routine tooth work, dental work done while on bisphosphonates. It's really when it gets to be a real surgery where we hedge a little bit with it. All right, so that was the bad. Now the confusing, now the fun part. So do you treat or do you not treat? I showed you how well they work when they work. I showed you some of the bad stuff that could happen with them. So how do you decide? So I would like to frame this part in the setting of two cases. I'm just going to present the two cases now. We're not going to solve them. I'll walk you through my reasoning when I work with a patient with osteoporosis. So the first case, and both are real cases from my practice. The first case is a 41-year-old Caucasian woman. She's been menopausal for just a few months. She's a non-smoker, drinks only 2 glasses of wine per week, no other medical problems, does not take any meds, no history of fractures, no parental history of fracture, really very low risk as far as bone is concerned. Her physician decides to obtain a DEXA because now she's menopausal, and she's found to have a T-score at the femoral neck of -2.7 and a T-score at the spine, at the lumbar spine of -2.3. So she is officially in the osteoporosis range. And she gets referred to my clinic to consider treatment. So my question to you as I continue through the rest of my presentation is to try to think, should she start a bisphosphonate? Here's the second case. An 85-year-old Caucasian woman, non-smoker, no alcohol, has history of atrial fibrillation, hypertension, TIAs, gets pre-syncopal episodes, has a tendency to fall, has already had 2 fractures, one in T5 and one in T12. Her mother had a hip fracture, so pretty high risk for fractures and osteoporosis. She's been on Alendronate for 6 years. Her current DEXA scan shows a T-score at the femoral neck of -3.7 and a T-score at the spine of -3.9. So the question this time is, should we give her a drug holiday? She's been on Alendronate for 6 years. Okay? All right, so to treat or not to treat? Honestly, it's all about balancing the risk and benefit. These are my rules, okay? So this is, there's some evidence base to it, but different endocrinologists might have different opinions about it, but these are the rules I go by. I do not use bisphosphonates in those who do not need it. And to be able to apply rule number 1, that means do not test too early. Sometimes you don't need to know about osteoporosis, so don't look for that information because then you're going to be facing the dilemma of what to do with it. And osteopenia does not always need treatment. And rule number 2 is limit the duration of exposure when possible. So let's go through the data on those 2 rules. That's rule number 1. Do not test too early. And this is data that's pretty old now, published in JAMA. It's been reproduced in other papers, but it basically correlated the T-score, and this is in women, but there's similar data in men. It correlates the patient's T-score with their age and estimates their 5-year risk of fracture per T-score per age. So what I want to point out here is that when you're in the younger age group, really your risk of fracture is pretty low no matter what your T-score is. Okay? And then for the same T-score, let's pick -2.5 as an example. So when you're 50 and you have a T-score of -2.5, your risk of fracture is not that much higher than the next woman who has a T-score of -1. And really the risk starts spreading out and kind of going up fast after that patient, after women hit the age of 65. So this is the risk of vertebral fractures. This is the risk of hip fracture. We have to keep in mind that there's a baseline risk for everybody. So, the general population does not have a risk of 0. But having osteoporosis would increase that risk. So really, when you're younger, your T-score does not alone predict all of your risk of fracture above your peers. Now, in men, there's similar graphs, but they deflect or they start moving up at the age of 70. So because of that, it's not recommended to screen women until the age of 65. And it's not recommended to screen men for osteoporosis until the age of 70. Unless they have risk factors, unless they're, say, heavy smokers, heavy drinkers, on glucocorticoids, something of that sort. But people who really don't have risk factors and who are healthy otherwise should not be screened until those ages, because really, at the end of the day, we're trying to prevent the outcome that is a fracture. And so it doesn't make sense to screen too soon when the risk of fracture is not high anyway, because our treatment is really not making a major difference in outcome. Remember that drugs decrease the risk of fracture by about 50%, so it's not like we're bringing that risk to 0. The other factor to keep in mind is the concept of low peak bone mass. I'm going to look at the solid line first, okay? We accrue pretty much most of our skeleton in our late teenage years. Girls a little bit sooner than boys, but by the time we're about 18 to 20, we're done building bone. We've accrued all of our skeleton. And we have a general sense, and that is what we call peak bone mass or full potential. And we have a general sense for what peak bone mass is per sex, per race. So we kind of know, what, say, a black male at the age of 20, what his bone density should look like. What a white female, what kind of bone density a healthy white female should have by the age of 20. So we have normative data for different races and the different sexes. So that's all good. And then we keep that bone density for most of our adult life until a woman hits menopause or a man is about 50, 55 years of age. And then our bone density starts declining either as a result of menopause or just as a result of aging after that. Okay? Now, usually we check people's bone density here. We don't check it here. But the assumption is when I check my patient's bone density at any age in here, if I compare it to what I know the normal should be for that sex and that race, then I can make the assumption that my patient has lost that amount of bone over their lifetime, which is accurate in most people, but not in all. Because some people never reach their peak bone density when they are 20 years of age. And we don't have a good handle on why. Sometimes it's a pretty clear explanation. They had a major illness when they were kids. They were treated for leukemia. They were malnourished, something like this, where it's very clear that this child grew up but missed out on the opportunity to build their full skeleton. And sometimes we don't know exactly. It could be something genetic in the family. It could be that that child, was vitamin D deficient or was not drinking enough milk, drinking too much soda. I mean, people are trying to look at determinants of peak bone density, and there isn't a full understanding of what determines that. But we know for a fact that some people never land here, and they land somewhere in here. Now, we don't know that because we're not checking them, right? We check them here, and automatically we assume that they dropped from this peak all the way down to here. Or we might check them here, right at the time of menopause, like that first lady I told you about. We checked her right here. And the immediate assumption was, she's dropped from there. That's drastic, right? That's a lot of bone loss, if that's true. And that would make me worry about that patient, because if she's dissolving her bone to that degree, then that's bad news for her. When in reality, she's been living there her whole life. We just did not know it. Okay? Now, what difference does that make? It does make a difference because not all T-scores, unfortunately, we only can measure T-scores now. But not all T-scores are the same, because the patient who has low peak bone density but is not actively losing bone, their bone is thin, but it's well connected. It's well interconnected. Their trabeculae have good architecture. While the patient who was at a certain level and has lost their bone, they lose quantity, but more importantly, they lose quality. So not only does their bone become thinner, they actually lose that interconnectedness in their trabeculae. So they lose architecture. And the reason their bone becomes brittle and they break is not just because it's thinner, it's because it has lousy architecture. So the patients with low peak bone density are not at the same risk of fracture as patients who reached their peak and then lost it and then dropped their bone. So that probably explains that curve I showed you a couple of slides back that shows, the difference with T-score and age. That's why the younger women, even if their T-score looks ugly, the risk of fracture is not that high. The older women, they have a higher when their T-score is low, then that translates into a higher risk of fracture. Rule number 2. So that was rule number 1. Do not check too soon if you don't have a good reason to check, because you might stumble across a low T-score, but it doesn't necessarily mean a high fracture risk. And once you know it, it's very hard to unknow it, right? The second rule is osteopenia is not a disease. So if you find someone with osteopenia, meaning their T-score is below 1, but is better than minus 2.5, that is not an automatic ticket to treatment. You want to estimate the risk of fracture. So I would put them, we have a great tool here, which is FRAX. I would plug them into FRAX and estimate what kind of fracture risk does that bone density translate into. In the United States, the cutoffs that are recommended by the National Osteoporosis Foundation are a probability of 20% or more for a major osteoporotic fracture, or a probability of 3% or more for a hip fracture. Those would be the recommended cutoffs to start treatment. So if the patient hits that cutoff or above, then it's reasonable to put them on treatment. If they're below, then again, the T-score is just a number, but we care about outcome. All right, so with that, we'll go back to case number 1. 49-year-old woman with no risk factors. She has a T-score at the femoral neck of minus 2.7. So technically, she has osteoporosis by definition. But the points that I want you to think about is her DEXA was done much earlier than the recommended age. Menopause was within the last 6 months. If she's a healthy woman with no reason to lose bone, she's not on steroids, she's not smoking too much or drinking too much or what have you, it's not possible to lose that amount of bone in 6 months. A postmenopausal woman loses 1 to 2% bone mineral density per year after menopause. So I can't even imagine that she was at that peak that I showed you and she dropped all the way to minus 2.7 in 6 months, She got hit by menopause and her bone is dissolving. That's not possible. And then she's only 49. So even if I wanted to, err on the safe side and, just be super careful and what have you, if I commit her to treatment, then I'm committing her for a long, long time. She has a long life, hopefully, to live. So with that, would you start her on a bisphosphonate? I'm seeing head shakes, no. So that is, that's what I did. I did not start her on a bisphosphonate. It was a long discussion with the patient, and it was a long discussion with myself to convince myself to unknow the minus 2.7, right? But when you look at the literature, when you look at the estimates of fractures, I could not convince myself to go ahead and commit her to treatment either. Okay? So that's why sometimes it's better not to know. And you're not committing a mistake but by not knowing. Now, if you read any textbook on osteoporosis, it will not get into that level of detail. It will tell you, treat if the patient has osteoporosis. But 5 pages earlier, that same textbook told you, do a DEXA scan when the patient is 65, not when they're 49. So this patient I cannot find in a textbook. So this is where you have to kind of personalize based on the available knowledge. Now, to convince myself further, I put her into FRAX. Now, strictly speaking, I'm violating my own rule here. Strictly speaking, you should not put someone with osteoporosis in FRAX, because FRAX is not a tool for osteoporotic patients. It's validated for osteopenia only. We all know this. We all ignore it. Okay, just to convince myself, I said, Even though I know it's not for osteoporosis, I'm going to plug her into FRAX to see what I get out of that. So I put her low T-score in FRAX, the minus 2.7 at the femoral neck. I put all the information I've got about her. FRAX told me, I don't think you should treat her because her risk of a major osteoporotic fracture was 6.8, less than the magic 20%. Her risk of a hip fracture was 1.9%, less than the magic 3%. So that just gave me more reassurance and gave her more reassurance that we're not doing something egregious, deviating from the best statistical practices here. Any questions about this patient before I move on to the next one? That's a hard one. Sometimes because they come in and they're very, so the question is, when do you repeat the scan for those who are not in the room? Obviously, you can imagine she's very anxious. So I repeated it 2 years later, primarily to convince myself that she's not losing bone like there's no tomorrow, that I didn't miss something bad. And usually, if I get the second scan and it's relatively stable, I mean, she's going to lose some. She's postmenopausal. You know, I do expect a 1 to 2% drop, but not a 10% drop. So if my predictions work, then I tell her, forget about it, and your next scan is when you're 65 or 60, depending on, you know, the level of anxiety. But that's the problem, is we end up spending so much time and so much money when we really didn't need to be in that situation to start with. All right. Now, rule number 3 is limit the duration of exposure if possible. So if your patient needs to be on bisphosphonates, then that's fine, but try not to let it drag forever if it doesn't have to drag forever. What this slide shows is that the risk of a subtrochanteric fracture decreases by about 70% with every year that the patient has not taken the bisphosphonates. So if you treat them for a certain period of time and then you stop it, every year it will drop by another 70%, roughly. Now, there's some statistical modeling that goes into that because the actual study was not that long. I think it was 2 years long. So they took that data and extended it over time. So there's some statistical tricks into that go into that graph. But the point is, you know, try to treat them for as long as they need to be, but if you're not getting much out of treatment anymore, give them a break. You will substantially decrease the risk of subtrochanteric fractures. And is it safe to do it? How about osteoporotic fracture? You know, I'm going to stop it to decrease their subtrochanteric fractures, but am I going to give them a ton of vertebral fractures and a ton of actual, like, femoral neck fractures from osteoporosis? The answer comes, I think the best answer comes from the FIT trial, which is the original Alendronate trial. So the FIT trial enrolled postmenopausal women for 5 years, and they gave them either Alendronate or placebo for 5 years. This is what I showed you earlier. This is where the bone density got better and the risk of fracture got down, and all is good at 5 years. Now, when they finished, they took the group that was only on Alendronate. They took out people at high risk, and they defined that by people who had a T-score at the hip of less than minus 3.5, and people whose bone density declined while on Alendronate. So they excluded those people, and whoever was left, they re-randomized them to continue Alendronate for another 5 years. So now you have a group who's getting Alendronate for a total of 10 years, or to go on placebo for 5 years. So this second group took Alendronate for 5 years, then nothing. And that's what they found. So the initial graph is when they were all on Alendronate, and I showed you that before. Their bone density, this is femoral neck, and this is lumbar spine. Their bone density did go up. And then that's the first 5 year-ish. And then they were randomized to stay on Alendronate for another 5 years, and that group continued to experience a little bit of improvement in their bone density at a lower slope, at a lower rate, but it held its own or got maybe a little bit better. The people who got on placebo, which is the blue line, their bone density did drop over the 5 years that they did not take Alendronate. It did not drop too drastically, it dropped slowly, and more importantly, it did not go below their baseline. And you've observed the same phenomenon at the lumbar spine here. So you lose bone density when you stop the bisphosphonate, but you're not going to lose it immediately or very fast. You've got time to watch it and to react. More importantly, there was no increase in the risk of fractures. There was actually an increase in symptomatic vertebral fractures, so the fractures that brought the patient with back pain. to their providers, but there was no increase in radiographic fractures during that 5 years. So this is called the FLEX, the extension of the FIT trial. So the FLEX study shows us that in the right patient, you can give the patient a drug holiday as long as they are stable or improved when they were on bisphosphonates. So as long as they had a favorable response to the bisphosphonate to start with, they don't have ongoing risk factors such as glucocorticoids or heavy smoking or something that's working against their bones. They're younger and healthier as a general rule, and they don't have major fractures. So if you pick your patients carefully, and basically you're picking the lower risk patients, you can give them a break from the bisphosphonate. A couple of things to remember. Protection from osteoporotic fractures with a bisphosphonate is about 40 to 50%. The risk of a subtrochanteric fracture is 1 in 1,000 per year. So if I'm an older woman and my risk of an osteoporotic fracture, say, is 20%, then what I'm getting out of a bisphosphonate is an absolute risk reduction of 10%, right? 10 in 100, 1 in 10. What I'm getting out of it in terms of risk is a risk of subtrochanteric fracture of 1 in 1,000. So clearly the bisphosphonate wins in terms of benefit. But if I'm a 49-year-old woman and my risk of fracture is 2%, and I go on a bisphosphonate, then I'm getting an absolute, it's cutting my risk in half, but my true absolute risk reduction is really only 1%. So then you have to think, you're giving me a protection of 1 in 10 and 100. So is that really worth it when my risk of a subtrochanteric fracture is 1 in 1,000? The risks are coming too close to each other, right? Or closer. I say here 40 to 50%, but you really have to look at the initial risk of fracture because you want to think about absolute protection. So back to my older lady. So 85-year-old with fractures. She's been on Alendronate for, in my previous slide I said 6 years. Here I'm saying 7 years. So 6 to 7 years. At this time, she has a T-score at the femoral neck of minus 3.7. So to start with, she wouldn't have met the inclusion criteria in the FLEX study. If she was in that study, they would have excluded her because they excluded people with a T-score of below minus 3. So she's already kind of in that, what they defined in the FLEX trial as a high risk. Risk assessment, you want to think about which is higher, her risk of a subtrochanteric fracture if I kept her going on the Alendronate, or the risk of an osteoporotic fracture if I stopped her Alendronate. And then she has pre-syncopal episodes, and she does fall, and she's at risk of falling. So this is a frail woman where every day she is at risk of breaking her hip or breaking a vertebra. She's already had 2 of those. So the question is, she's been on it for more than the magic 5 years, but do I have the guts to stop it? And what do you think my answer was? I did not. I did not have the guts to stop it. Because think about it, she's 85. What's her longevity? I mean, how long is she going to live? What's the average longevity in the United States? We're about there, right? Maybe another 5 years, I don't know. So if she can live those 5 years without a hip fracture, that would be great. But if I give her a femoral neck fracture because I stopped her bisphosphonate with her high risk of falling, then that probably will be it for her. She's probably going to have some post-op complication that will do her in. So typically in older people like that, especially if they're high risk, we tend to be more aggressive because of all these calculations. Now, to convince myself that I'm not goofing too much, like that's not too wrong, again, I broke my rule again. I'm not supposed to put her in FRAX because she has osteoporosis and FRAX is only for osteopenia, but I did put her in FRAX. Okay, she's 85, that's her weight and height. She does have a history of prior fracture. Her mom had a hip fracture. These are her risk factors. Here's her T-score. This is her estimated 10-year risk of fractures. 60% for a major osteoporotic fracture and 50% for a hip fracture. Now you might tell me, but this would have been at baseline. She's already been on bisphosphonates for 5 years, right? So even if I cut that by half, right, because bisphosphonates will slash her risk in half. So even if I gave her 30% risk for a major osteoporotic fracture and 25% risk for a hip fracture to account for having been on Alendronate, that's still very high. That's still a very high risk in someone who's falling frequently. So in this case, the decision was, let's keep going. I'm not going to give her a drug holiday. So really the take-home points are effects of bisphosphonates, the positive ones, they increase bone density, they give us up to 50% roughly, some are a little bit better, of fracture protection. On the negative side, they decrease bone elasticity, they lead to accumulation of microcracks if we overuse them, which puts us at risk for atypical subtrochanteric fractures. The risk of that is about 1 in 1,000 per year. So really at the end of the day, it's all about fractures, not numbers. You need to base the decision to screen on your estimated fracture, a priori fracture risk. So if your patient a priori is not at a high fracture risk, do not do a DEXA on them. Do not do a DEXA on a 50-year-old healthy woman. You need to base your decision to treat on their estimated fracture risk, not just on their T-score. And you need to base the decision to stop, again, on their fracture risk, not just duration. So, just clear-cut algorithmic rules do not necessarily apply in every patient here. There are guidelines, but we've got to think of the context of the patient for those decisions. And I think that's my talk. I'm happy to take questions. Yes?
What about someone that already has resorption of the lower jaw, and I've lost 3 teeth because of it?
What about someone who already has resorption of the jaw and they've lost teeth because of that? They can go on a bisphosphonate because the bisphosphonate doesn't affect that. If anything, actually, it will help them retain their bone.
Okay. Are there any side effects to being on biphosphonates? I mean, like body aches, anything
Are
like
there
that?
side effects to being on bisphosphonates? The intravenous one, the zoledronic acid, can give you an acute phase reaction for anywhere between a day and 3-4 days after the infusion, can give fever, chills, like you're coming down with the flu, a lot of aches and pains. Usually it resolves spontaneously within a couple of days. Alendronate and all the oral ones, they can give body aches, but it is not as common. More often, most often what the patients who have had body aches with them, who have reported to me, they say, after I take it, I'm achy for a day or so. And then it goes away, or I'm achy for a couple of days. And someone, in those cases, I try then to give them something that they don't have to take every week, so they're not miserable 2 days of each week. We try to go with a monthly, or maybe we try to go with the yearly, just so they're only miserable for a couple of days a month, or what have you.
And my last question, if someone has a fracture while they're on the biphosphonates, does it take longer for that bone to heal?
If someone has a fracture while on bisphosphonates, does it take longer for that bone to heal? The general feeling about this is probably not. There's 2 main studies that looked at that. One was a retrospective study that looked at patients who were on bisphosphonates and had fractures, and kind of went back and looked at how long did it take for them to heal. So the patients who were on bisphosphonates at the time of fracture, it took them a few more days to heal, but it was not, so it was statistically significant, but not like clinically significant. It didn't take them like forever more, just a few more days. But the more important study that was randomized, double-blind, placebo-controlled is the zoledronic acid study called the Horizon trial. That study actually was done on people who had a hip fracture. So all the patients in that study were enrolled after they sustained a hip fracture and were given the bisphosphonate anytime between immediately up to 3 months from the fracture, depending on when they happened to enroll them in the study. And there was no delay in healing. And they even looked within the group that got the bisphosphonate, whether the timing, whether they started it immediately or like a month later or 3 months later, whether the duration to initiation had any effect on healing, and they didn't find any effect on healing. So in general, we don't worry about healing in the setting of bisphosphonates. Yes?
What's your recommendation for vitamin D levels? Younger patients, should they be on vitamin D supplementation, or should the providers check the vitamin D levels?
What are the recommendations regarding vitamin D levels? And in a younger patient, should that be checked or should they be put on supplementation? The Institute of Medicine recommends a vitamin D level of 20, above 20 for the general population. They could not find any, they could not prove any benefit from pushing it higher. So the general population, if we're not worried about bone disorders, 20 is the cutoff. Now, do I recommend checking it in everybody? It's not recommended to check it in everybody, but if you have reason to worry about it or to suspect it's going to be very low, then you could check it and supplement at that time. Now, in people who have osteoporosis or metabolic bone disease, there is some data that suggests that the bone density is better if the vitamin D is above 30, and the risk of fracture and falls might be a little bit better if the vitamin D is above 30. It's not a huge effect, but big enough that, sometimes in these patients, you want to do everything to maximize the benefit. So in the bone patients, we recommend a cutoff of 30. And definitely we check it, and definitely we replace it to achieve above 30 in those cases.
Likewise, estrogen in those that are suitable candidates.
Effect of estrogen in those who are suitable candidates, yes, in general. So I'm thinking about the younger woman, say, who has premature menopause, premature ovarian failure, or a woman with Turner syndrome, or someone who had chemotherapy for leukemia and lost her ovarian function, something of that sort. I would definitely put them on estrogen replacement because estrogen is going to help preserve their bone health. So we usually put them on a birth control pill. And we recommend stopping it at the natural age of menopause, so about the age of 50 or so, 50, 55, depending on the preference of the patient. Now, in older patients, so after menopause, after normal menopause, so if you have a woman who gets into menopause at the natural age, if you put her on estrogen, you're going to help her preserve her bone density. She's not going to lose like a postmenopausal woman. The problem is you're starting to get into the risk of breast cancer, endometrial cancer, and then as they get older, thromboembolic disease. So as a general rule, it's recommended in that group not to use estrogen for bone purposes. If you hit a point where you're worried about the bone, there are plenty of drugs we can use that don't cause cancer and don't cause, are not associated with strokes or what have you. Now, if you want to use it for hot flashes to kind of ease the transition or what have you, you go for it and you do it until you feel like you can stop it, for symptom control. Thank you.